Good morning, everyone. Happy Sunday. I am tackling a requested topic, ARFID. And ARFID is so fascinating because, up until 2013, there was such a lack of understanding and essentially a diagnosis for ARFID. And it wasn't until 2013 that ARFID officially entered into the DSM-5 manual. That is the diagnostic manual for all mental health disorders. And ARFID stands for Avoidant Restrictive Food Intake Disorder. And essentially, it's incredibly complex, nuanced eating disorder in which there is significant food restriction and there is no body image component, right? So the biggest difference between ARFID and anorexia is ARFID, there isn't any necessarily body image driven restriction, whereas anorexia, there is a huge body image component. And so that is some of the biggest difference. And with ARFID, right, there are still, risks of malnutrition, reliance on supplements to meet nutritional needs. There can be weight loss or failure to thrive, or difficulty with adequate nourishment or adequate especially with my younger kiddos, failure to meet appropriate goals surrounding weight and even height due to the lack of nutrition and some height stunting. And so with ARFID, essentially, I like to kind of conceptualize ARFID as having 6 different presentations of ARFID. And what I see most often is with ARFID, right, the food selectivity, right? I have kiddos with ARFID that could eat anywhere from 7 foods. Some of my clients, when they first come to me, are at 20 foods, some are at 30. So it really all depends, but really limited. And there are there's main driving factors of why that happens. One of the most common is fear of eating due to fears of choking or vomiting. That is a huge fear. Food allergies is another one. Generalized anxiety disorder is another one. Gastrointestinal symptoms is a big one for these clients. And just picky eating since childhood. So these, I call them maintaining mechanisms. So why does ARFID exist? These are some of these driving factors: fear of vomiting, fear of choking, gastrointestinal symptoms, food allergies, anxiety disorder. So, right, these all have to be tackled in order to kind of increase or heal I keep saying kiddos, but my clients' ability to increase intake. So ARFID essentially is very low food variety, leading to nutrition inadequacy, nutrition deficiencies, and the reason why are some of these maintaining mechanisms that need to be addressed. And so one of the main things that I work on with my client, the first step is to, one, kind of see with lab work, where are their big nutrition deficiencies? Are we at risk for anything, right? I want to check lab work, I want to check height, I want to check their weight and see from a big picture, what do I need to supplement initially with, because it takes time to increase variety with this population. And so I want to make sure if I need to provide a nutrition supplement, I will do that right off the bat in order to fill in any nutrition gaps for that client. So that's the first step. The second step is getting a list of what are their preferred safe foods. Something that's really common is ARFID clients, they food jag. So we call it food jagging. They eat the same thing over and over and over and over and over again. And then all of a sudden they're like, I'm over it. I don't want this food anymore. So the food drops off and they go on to the next food. But with each food jag, they eventually get sick of it, remove it from their eating world, and their food selectivity gets more and more narrow. So the main goal is to, I guess the long-term goal is to slowly increase variety again. So first we make sure any nutrition deficiencies, how do we fill in all those gaps? The second step is what are their preferred and safe foods? And how do we increase the volume of those safe foods? So our first goal is making sure that the client is eating enough. I guess that's the second goal. First goal, medical stabilization, labs, nutrition deficiencies, address that. Second goal is increasing volume, making sure they're eating enough overall. This is a really big piece of most of my clients with ARFID are afraid that I'm immediately going to be like, okay, food exposures, let's increase variety. And they're like, wait, what? No, I'm not ready. And I'm like, that's not the first step. We have a couple steps before that of nutrition deficiencies, increasing volume of preferred safe foods. Then once we get their appetite back and they're feeling a little bit more nourished and increasing volume of these foods, then there's this whole other process that we do around fear food exposures and increasing variety and challenging any of the maintaining mechanisms, right, of fear of choking, fear of vomiting, or if there's anxiety around food or GI symptoms. That all needs to be addressed as we slowly start doing food exposures. So I love working with ARFID. It's a fascinating diagnosis, often misunderstood, and it kind of gets lumped into the same eating disorder diagnoses, which there are similarities for sure in how it impacts the brain and body, but I kind of focus on a couple of different things first before jumping right into increasing variety. So hopefully this is helpful. Please let me know if you have any other questions about ARFID or if you want any more explanations on everything. All right, everyone, thanks so much and have a happy Sunday.